So yeah, before I will start, I would like to do the acknowledgement of country. I have to say I feel very inadequate to try to do any justice to it. I come from a European country with a quite horrific history of colonization. So I asked how to do this, and I hope I get it right. So please bear with me. I would like to acknowledge the traditional custodians of the land on which we meet here today. This conference has been held on the land of 5 tribes of the Kulin Nation. Do I pronounce that right? For those from Australia, is that correct? And I wish to acknowledge them as the traditional owners. I would also like to pay my respect to their elders, past and present, the Aboriginal elders of other communities who may be here today. And sovereignty was never ceded. This always was and always will be Aboriginal land. Thank you. My name is Ernst. I work with a humanitarian medical organization called Mits aan de Monde, Doctors of the World. There's another colleague there, another colleague I see here in the room. I hope there's still a bit more people coming in, but we are competing with a lot of very interesting topics, as this whole conference will be. So we will be talking about COVID, right? COVID, that was quite a roller coaster in the last few years. I had the dubious pleasure to be part of the group of people that had to go through the abstracts about COVID, and our pile of abstracts was phenomenal. All the other groups were looking at us like, well, good luck with that. And it made me really realize that a lot of what we've been doing in the last 3 years was about COVID, wasn't it? I mean, everything that we are already doing, and then on top of it, we had COVID. So this is not just a session about COVID. It is very diverse. It is really reflected. We will hear from prison, overdose, hepatitis C, peer work, homelessness, integrating services, sex work. There's a whole diversity, and all of that then compounded by the complexity of COVID. We also have a very diverse input from all over the world, I would say. We have somebody from Australia, Chris. Is that you, Chris? All right, good to see you. From Myanmar, Mio is here as well to answer questions if need. Bangladesh, Canada, and some of global perspectives. So, I don't know about you, but in the beginning of the COVID epidemic, I didn't really know so well what to do and how to go about it. So at that time, I wasn't actually in the field in a position. I was working as a technical advisor to all the other field teams, so I can't imagine what it is to be directly in the front line. But at some point, we said, okay, let's just at least have a conversation among ourselves, like who is doing what around the world, and you could just realize that we as a harm reduction movement, I think we are really used to swim upstream. We are constantly facing troubles, and we're always joking with the field team, if you don't have any problems in your project, then you're probably not pushing the boundaries hard enough, right? We're just constantly swimming upstream. We're really fighting the system and everything that is facing us. And then you had COVID on top of it. Well, thank you very much. That was an extra blow to our face. But what I also really realized straight from the beginning is that perhaps we are one of the most resilient movements as well in the world, because we are so used to swim upstream, aren't we? We are constantly adapting. We're constantly having more. Hi, Zoe. No worries, no worries. We are constantly fighting. All the odds are against us. And yes, COVID was thrown at us again. Another punch to our face. We were locked down, but we were definitely not knocked out. And I think that is really the theme here today. We will hear about field experiences from many places in the world, all the complexities, but as well, very importantly, how our community manages to face and not be knocked out in the face of so many resistance. I find it really important as well just to add on that most certainly from our perspective, but I've heard it from everyone, that in that whole fight, it has always been the community that was in the front line that are the most adapted, the most at place, fighting for their own community, and without them we would have not, all of our programs would have stopped. And you could really see, I find in the world, that if you had a really good community base to start with, you're much more resilient to these kind of interventions, or these kind of, what we hope will not happen again, all the shit that is thrown at us by the world. So, all right. let's get down to it. I think this session is also streamed online, so if you want to say hi to your mom, I think the camera's over there. Smile. We're quite lucky to be in a speed session. I like those because I have a very short attention span, so 7 minutes is perfect. We will run out, that is fine, but we will definitely make sure that we get all of you guys engaged. That's the most interesting part of sitting in these sessions. Today we have a really brilliant group of people with us today. We have Flippa is here from New Zealand, Marcela from, where are you based at the moment? Oh, you're London. Okay, you're from Chile, right? Okay. Carol from Canada, Lisa and Zoe are here from Canada as well. You'll hear from Lidi from Myanmar, but Myo, who used to run the program before, is here. I don't know how he did it. He's the only Burmese person that got a visa, I think. Well done on you. Well done on you. Exactly. Chris is here, and Omar from Bangladesh. So we have a really diverse group of people. I'm really looking forward to hear from all of them. Now let me look at the order. Yeah, I went through it 7 times. I still don't know it, Zoe. Marcela, you're up first. That is fantastic. We will hear from Marcela on prison, if I got it right. Thank you very much. Also, just for everyone, I hope you're okay. Everyone will sit here because otherwise we'll be just staring in your face all the time. In the end, everyone will come here and we'll answer questions. All right, up to you. I think over there you have the...
Okay, so hello everyone. Firstly, I'd like to pay my respect to the traditional owners of the land we are meeting today. I acknowledge their connection with the land whose sovereignty has never been ceded. So the findings I'll be briefly sharing with you today are from HRI's most recent report on this topic. But also this work is part of a bigger endeavor to put people in detention at the center of policy making and pandemic preparedness and response. As the title of my presentation suggests, my presentation is going to look at how COVID-19 measures in places of detention have impacted the provision of health and harm reduction services as well as human rights, to see what lessons, if any, had been learned from the pandemic to promote and protect the right to health for people deprived of liberty, particularly those who use drugs. There you go. So in terms of the methodology, we conducted a survey and gathered information about the situation before, during, and after the pandemic in 15 countries mentioned in the slide. And we focus on particularly relevant services for people who use drugs in prisons, such as OAT, NSPs, HIV treatment, drug education programs, and contraceptive methods. So let's see what happened before the pandemic. So as we know from the global state of harm reduction and this research, prior to the pandemic outbreak in 2020, the provision of health and harm reduction services was already limited. And even when available, these services were often not widely accessible. For example, one of the most common barriers identified was the lack of information about the services available, inconsistency and equal provision of health services, and lack of confidentiality. So during the pandemic, all 15 countries analyzed adopted measures to curb the spread of COVID in prisons, being the most extreme of them full lockdowns, preventive isolations, and restriction or suspension of visits. This measure, despite being necessary to some degree, limited the availability and accessibility to key health and harm reduction services in prison. Lockdowns and preventive quarantine severely limited or fully suspended people's access to essential services for extended periods. For example, lockdown in some cases were applied for an extended period of time, for example, sometimes 23 hours up to 24 days in the case of Canada, and were recurring in several stages of the pandemic. Preventive isolation, as well, limited the access to outpatient care, with some people refusing it, despite the health risk, just to avoid having to spend weeks in preventive quarantine on their return to prison. Also, all countries also suspended or severely restricted prison visit, which prevented not only family and friends from coming into prison, but also external services provider. In the 15 countries we looked at, this impacted the provision of essential harm reduction services, mental health care, testing and treatment for HIV, viral hepatitis, TB, and transfer to hospital for specialist appointment and care. The effects of these are still being felt in some countries. Shortage of essential medicine and medical staff in prison was also reported in 9 countries. And even with this measure in place, prison is in most countries still experience several COVID outbreaks. So in some countries, this emergency measure continued to be implemented in prison years into the pandemic, and in some cases are still in place today, raising questions about their exceptional or temporary nature. Lockdown, for example, continued to be imposed in prison long after they were lifted in broader community in many countries. In the UK, for example, a large proportion of people in detention were still being locked up for 23 hours a day in February 2022, 2 years after the pandemic outbreak. Prison visits have resumed in most countries, but not like before. They are often less frequent and much more restricted now. Visits remain entirely suspended in some Canadian prisons, and visits in at least 4 prisons in Mexico have been permanently reduced. And the prolonged nature of this measure has resulted in severe isolation of people in detention and has caused serious harm on their already fragile mental health and well-being. So just to wrap this up, I'd like to share 3 or 4 concluding remarks. First, while extremely restrictive measures may have been justifiable and proportionate for a time, the longer they remained in place, the more this became questionable. Indeed, the severe measures imposed in prison were often disproportionate and have made people deprived of their liberty more vulnerable to health and human rights harms and abuses. Some of these measures analyzed likely had the effect, and either directly or indirectly, of violating absolute right by obstructing access to essential medicine and health for extended periods of time. Secondly, as less restricted means of controlling the COVID became available, such as prison decongestion, vaccine, and rapid tests, they should have replaced the more restricted ones. The fact that some of these measures are still in place in some prisons suggests that they have become normalized and a routine practice, as opposed to a temporary in nature. Thirdly, governments had and continue to have an obligation to apply a human rights framework and prioritize more effective and less restrictive approaches to manage the crisis and minimize the negative impact of prisoners' health and human rights. However, they likely failed, at least at a certain point, to meet these criteria to justify the use of COVID measures in prisons, as they were disproportionate, arbitrary, and abusive, giving rise to concern that they could, in some cases, amount to violation of the right to health and the prohibition of torture and ill treatment. And finally, As we come up into the 3 years since the COVID outbreak, we must reflect closely on the failings and lessons learned. In this regard, alongside loudly advocating for the decarceration and decriminalization, we need to work to ensure that initiatives to set standards and policies for pandemic prevention, preparedness, and response at the international level pay specific attention to the particular needs and experience of people deprived of liberty. Thank you.
Marcela, thank you. We will move on very swiftly now. We go to Canada, right? Up to you, Lita.
All right, great. So, hi everyone. So today I'm presenting a study that Zoe Dodd over there and I co-led to evaluate the outreach supports provided to people experiencing homelessness in Toronto encampments during the pandemic. We're presenting this in memory of our dear mentee, Abeera. She was a brilliant young medical student, contributed greatly to this work, and she submitted this abstract to the conference, but sadly passed away a few months ago. Our other team members are also listed on the slide, and this study was part of a larger Marco, the name was Marco study, and the link is shown there for more information. So first, we just want to acknowledge the original owners of the land where we are today, as well as where the study was conducted, and just to note that this is especially important to our work because there's a disproportionate number of Indigenous peoples in encampments, and we must respect their distinct right to self-determination, self-governance, and understand that encampment evictions are deeply harmful and perpetuate colonial violence. So just to give a quick background on the topic, there were many reasons why people ended up living outside, more so during the pandemic, such as the high rents and the risk of COVID in shelters, less shelter beds, loss of income, etc. The response by the city, they did open some more shelter hotels to support physical distancing, but those were limited in number and sometimes far from people's communities. And the community response, many organizations expanded their services and new groups formed to fill support gaps for encampment residents. So we wanted to know what outreach supports were provided and did they meet encampment residents' needs, and what roles and challenges did workers and volunteers face in providing outreach. So we conducted 127 surveys and 23 interviews with the encampment residents and 16 interviews with outreach workers and volunteers. We recruited from 6 different encampments and included key informants from 6 different outreach organizations. And as you can see here, we found a diverse sample, including many people who identified as LGBTQ or racialized identities, especially Indigenous. So obviously in this session, we can only give you a tiny snapshot of our overall findings. So firstly, substance use was common in the encampments, with 82% of people using non-prescribed substances. People discussed using to self-medicate health issues, but also often just to cope with living outside, and that's why there was greater stimulant use as people wanted to stay vigilant for their safety. So on the whole, people spoke very highly of the community connections they developed in the encampments, and one of our most prominent findings was this importance of mutual support among encampment residents, which is directly in line with the conference theme. We've actually published a scientific article on this topic if you want further information, but mainly just to say that people described finding a trusted community or family in the encampments and supported each other with watching, belonging, sharing food, helping with many different things. So also critically in our setting, the long-standing drug poisoning overdose crisis was an important part of encampment residents' lives, with 29% having experienced and 79% having witnessed an overdose requiring naloxone in the encampment. However, residents said that overdose was less likely in encampments compared to the shelters and shelter hotels because people actually could watch out for each other more easily in an encampment and were more separated and more they had to hide more in the shelters. And then, of course, also the outreach provided harm reduction supports directly to encampments as well. As for our broader findings about outreach supports, so encampment residents said they really appreciated supports being frequent and consistent, flexible and responsive to their feedback, and providing them with social connection. And the community-based workers and volunteers reported 2 key elements of their outreach supports, and that was having a relationship-centered and an autonomy-centered approach. So they aimed to enhance community connectedness and self-determination of encampment residents. They listened to residents and provided the supports that people needed most. Of course, they couldn't provide housing. That was the one critical limitation. Also, workers and volunteers described part of this work being needing to engage in extensive advocacy to counter the City of Toronto's harmful narratives about encampments, which were focused on just clearing encampments and getting people inside, and considering inside being safer, which wasn't consistent with residents' definition of safety. And then, of course, so encampment residents reported losing many friends, family members, and partners, actually finding people dead, witnessing people who moved from encampments into these shelter hotel spaces only to fatally overdose days or weeks later. And actually triangulating these reports from our participants with the coroner and city data, it was clear that there was a much higher total number of deaths in the shelter spaces than in encampments. And then the outreach workers and volunteers also described the immense burden of bearing witness to traumatic events, including extreme deprivation, violence, and death, which were life-altering for some new volunteers, and they worried about the sustainability of their outreach services due to a lack of resources and meaningful policy change. And then just overall, we had 40 overall recommendations, so this is just the recommendations related to overdose. So we recommended that principles of harm reduction and overdose death prevention be widely adopted by shelter staff and integrated into programs and policies. All shelter hotels and other shelters should have oxygen and naloxone readily available, have regular training for staff, peer-to-peer witnessing and spotting, and be equipped with overdose prevention sites and supervised consumption sites for both injection and inhalation, and run by workers, including people with lived experience. And these settings should also have integrated safe supply programs. And just to recognize that people living in encampments often respond to overdoses among their peers, their efforts should be recognized, and they should have access to trauma-informed mental health supports, including grief and loss, and that should be expanded, made accessible to people in encampments, but also the outreach workers and volunteers. And then for our overall report, so the core value underlying all our recommendations was that the provision of human life should be a collective responsibility. So housing policy should make sure that people do not suffer or die from preventable causes. We recommended the city acknowledge, and all cities, that homelessness is a humanitarian crisis, and they should truly adopt a human rights approach to address it, which includes divesting from the evictions and enforcement that they were focused on, and investing in these community-led supports like outreach and, of course, permanent housing. And the city should make significant efforts to prevent people from becoming evicted in the first place, of course. And then most important finding over our whole study pretty much was that encampment residents know their own needs best. So all decision makers should be including and listening to them in all discussions that affect their lives, which was not being done, of course. I just kept that in, and if anyone wants further information, there's links to a lot of the things I talked about here, including our 80-page report. And then, yeah, just thank you. You can also contact us.
Thank you very much. I just realized I haven't done much justice to introducing everyone with a proper bio. I even asked in an email specifically, can you please give me a bio? And then I just roll over it. I'll come to it at the questions and answer sessions, just to speed up we want to get into the content, and then later we get to the questions, if that is okay with you all. While I think the next one will be a video. It is from a Burmese program, and we will shift to sex work for the moment, but we are very lucky to have Myo here, who used to work on this program. So any questions he will be able to answer later. So yeah, shifting to Myanmar now with Lidi.
How many of us were forced to change plans in 2020? And how many of us had to adapt our programs every week, sometimes every day, or even the morning of an intervention? And I know you can relate. Now, how many of us face the reality of an overwhelmed national health system during the pandemic and after? Probably all of us. My name is Lydie Back. I'm a harm reduction advisor for Médecins du Monde France in Myanmar, and today I represent you our intervention in Yangon for female sex workers during COVID-19 in 2020 and 2021. Yangon is the former capital city of Myanmar. It is the largest and the most densely populated city of the country. And as a main economical center, Yangon attracts women and men looking for job opportunities. According to the local network SWIM, which stands for Sex Workers in Myanmar, there were in 2019 about 60,000 female sex workers in Yangon. They work on streets, indoors, like in brothels, guest houses, massage parlors, KTVs, clubs, and a minority would work on internet. Female sex workers are very mobile across the country, but also within the region and in the city of Yangon. Myanmar has one of the highest prevalence of HIV in Asia, and still access to healthcare may not be easy. Médecins du Monde operates in Myanmar since 1994 and has a dedicated program for sex workers and LGBTQIA+ population in Yangon since 2000. We are working with peers, with community-led organizations and the local stakeholders. Our objective is to transfer the developed activities to the local actors. And actually, before 2019, two transferring plans were scheduled. The clinic patients cohort to national program, but also the prevention activities to local community-based organizations. But these two plans were put on hold and delayed as the pandemic started. COVID hit Myanmar like the rest of the world in 2020. The first COVID case in Myanmar was registered mid-March, and at the same time, entertainment venues closed. And then shortly after, in April 2020, curfews and partial lockdown were in force in different townships of Yangon. For a long time, transportation services were greatly impacted, making extremely difficult for people to reach INGO's facilities, but also to reach public hospitals. And starting from this period, access to treatment or even most basic healthcare services may have been very challenging for safety reasons. Our response relied on peers. Peers within the team played a main role in ensuring the continuous service delivery for female sex workers in Yangon. They are in front line to keep contact with the beneficiaries and to provide all kinds of support to them, but also with key actors, with venue owners, with managers. A secondary distribution of material, condoms, pamphlets, was organized and massively relayed by peer workers doing outreaches from their home, but also by self-help groups and sex workers networks. I can mention to you Home Sweet Home or SWIM, who do amazing job for sex workers in Yangon. Testing performed by peers also was a good option for smaller scale intervention when social distancing had to be followed, but also for security reasons when gatherings were limited. And last but not least, I wanted to mention that in the context where no sick leave, no health insurance was provided, the community collected financial support for female sex workers. Médecins du Monde was then in charge to distribute this support to smaller community organizations. And by the end of 2021, 400 female sex workers received food and essential products vouchers. We maintained all of our activities, but we had to adapt them. Our outreach activities were set with a minimum package of prevention services. Constant remapping of the prevention interventions had to be done according to the movements of female sex workers, according to the opening, the closures of the hotspots, according to the security assessments. We also had to resize, for example, the attendance of our health education sessions at the DIC. Here are some data about our prevention interventions, and I wanted to talk to you also about linkage to care, which was and still is very challenging. We had overwhelmed healthcare facilities due to COVID-19, and then the local social and political context since early 2021. This urged us to strengthen more than ever the availability and the accessibility of free of charge medical services. It was possible up to a certain point to ARV treatment adjustment for patients with a good adherence. Procurement was under constant assessment and recalculation to maintain and to extend the medical services if possible. For example, for patients who faced great difficulties to get treatment from public facilities. The whole healthcare system was hit in many ways at this period. Public healthcare coordination, our usual focal points, may have left the public hospitals. Treatment procurement and supply processes were completely reorganized after 2021. And in these conditions, transferring was not an option. Again, here some data, but I wanted really to finish with some updates about the program. COVID is slowly going further from us. But many challenges remain in Yangon, and the healthcare system is currently still extremely fragile. The transfer of our prevention activities to local community-led organizations was completed by the end of 2021, but then the transfer of patients followed at the clinic and receiving ARV treatment was more delicate, and it slowly resumed starting only from the end of last year. We are still closely working with the community and local self-help groups today to collect their needs, to think about the solutions we can provide, and also to deliver trainings to build their capacities. Thank you so much for your attention.
Thank you in the back for making all that running with videos and presentations one after the other. I'm Dutch as a background, so I have time is sort of a religion for me. You know, I always try to be really on time, but I think we're doing really, really well. So I'm going to change my mind and just, do honor to all the bios that has been sent to me up front. You're really listening to a very rich group of people here. So first of all, we heard from Marcela, working now with HRI. And Marcela, before joining Harm Reduction International, you were already working as a criminal lawyer for more than 4 years with experience in criminal and strategic litigation in Chile. I don't even exactly know what that means, but it sounds very impressive. Then we heard from Lisa about overdose in Canada, and of course we already heard many times about this horrible crisis, which is still not over. Lisa is a postdoctoral fellow at the University of Ottawa and the Brewery Research University. Did I say that correct? Fantastic. She has a PhD in epidemiology and public health and a master in psychology, and she's joined by Zoe, who can also answer questions in the end of the session. I think many people of us know Zoe already. If you were there last time in the Harm Reduction Conference, there's also a session about overdose. Unfortunately, it is still as relevant as it was 4 years ago. Zoe is a well-known, long-time harm reduction advocate, organizer, activist and a scholar. She's currently working at the MAP Center for Urban Health Solutions in the St. Michael's Hospital. Then we heard just from Lydie, who's now working with MDM in Myanmar. She used to work as a human rights. Used to work on human rights in China before. She joined our program in Paris on a Chinese sex worker program that is still running today in Paris. And we have also we're lucky to have Mio here, who used to work with us before and used to run this sex worker program in Yangon with MDM before. And now we're very lucky to come to Carol. Carol is a professor at the Dalai Lama School of Public Health, University of Toronto, as a health service researcher. She works with and for people who use drugs to improve services and outcome. And as it is from the same region, we will hear again of overdose, but as well on safe supplies. There are, of course, specific sessions on overdose and safe supplies, but I find it very interesting that we're looking here in a perspective from COVID-19. Over to you.
Great. Thank you very much. So I am going to be talking about safer supply and the impact of COVID-19 on the people who receive safer supply and the people who deliver it. I would like to pay my respects to the elders past and present and the Aboriginal elders of other communities who may be here today. Safe supply programs aim to prevent overdose deaths. They provide an off-label prescription for take-home Dilaudid in the province where I'm from, and which is often paired with an observed daily prescription of Cadian or slow-release morphine, and sometimes with methadone, although that's not often the case. As I said, the models vary across Canada. In Ontario, where I'm from, the programs are offered primarily in primary care settings, community health centers, and the like, and there are currently about 25 federally funded pilot projects in Canada. I didn't read the instructions right, so I have a longer presentation, and I'm going to skip through some things. Anyway, we did a qualitative study. We talked to 52 people in 4 different sites in Ontario about their experience of being in the programs, and this presentation focuses on COVID. We also talked to people who delivered the programs, the prescribers, the pharmacists, and the allied health providers. So just to give you a sense of what COVID was like in the province where I lived and where these programs were delivered, we had 3 stay-at-home orders. We had staged reopenings, and it caused a lot of opening and closing and opening and closing, and some things never reopened in the ways that they had before. And that had a profound impact on harm reduction in general, and in particular on safer supply. When we asked people in the safer supply programs about the impact of COVID on their lives, they talked about it was a widespread impact in all aspects of their lives. As I said, they were subjected to opening and closures of supports and services. They were open, closed, with restrictions put in place. And for many of them, what it meant was a loss of very basic supports on which they depended. So food, shelter, water, toilets, laundry, showers, and sometimes for months on end. So these programs, they're embedded in community health centers that also have very expanded harm reduction programs. So they lost access to a lot of the programs. A nurse told us that, people, when they could come in, would just, say, I could kill for a shower, because they hadn't perhaps had a shower for over a month because they weren't allowed indoors to have one. People also, at the same time that we experienced COVID, the unregulated supply of drugs became increasingly toxic. It became more potent and also increasingly laced with benzodiazepines. And prescribers talked about how the tolerance that they had, that their clients were reporting and that they were prescribing for, just kept going up and up and up during the pandemic, which caused them quite a lot of worry about prescribing appropriate amounts. As the unregulated supply changed, and there were lots of changes going on in services, there were some new opportunities for housing, although insufficient in number. So there were COVID positive isolation and social distancing homes available, hotels available. And at the same time, there was an expansion of outdoor encampments that Lisa was talking about earlier. But not everybody wanted to go to them. Not everybody could get into them. And some really feared going into the social distancing hotels and preferred to stay outdoors. And there was a lot of problems with the outdoor encampments and the way in which the city perceived them, to the problems they perceived the encampments were causing without considering what the encampments offered people. People talked to us a lot about, during this time, they lost all their connection to their supports, and they lost a sense of belonging, of feeling accepted and being in a place where they were familiar, because all of a sudden they were in different kinds of places. For the safer supply programs, sometimes enrollment stopped altogether. And when they would reopen, sometimes they reopened with reduced capacity, and some people lost touch with people on wait lists. They lost touch with them, which caused the workers quite a lot of consternation, because people had been waiting. It was their time. They couldn't get a hold of them. Their cell phone had changed, or in some cases they believed they had passed away while they were waiting. For those who did go into the COVID isolation hotels, when they were discharged, they had no prescriber if they had been been started on Safe Supply, a measure to help them stay in the hotels. And the Safe Supply programs then felt that they became a priority for enrollment, which meant people on their wait list then waited longer. And they felt, often talked about being in an impossible situation. There was also a limited capacity overall in some of the programs. They talked to us about because of their funding, because of the indoor capacity limits of the programs, and they increasingly focused on more and more acute patients admitted to their programs who had, the most frequent overdoses, women who were pregnant, and so their client base became increasingly more complex to deal with because they were prioritizing those with the most complex needs. So despite the restrictions, as Ernst was saying, harm reduction is resilient, and the programs did their best to try to remain accessible. So some of them moved to phone and online appointments to make sure people could maintain their prescriptions. And for people who were working, that actually worked out really well for them because they could maintain Safe Supply and their employment at the same time, which was new to them because they could do their appointments over the phone. Some programs maintained in-person visits to the best that they could because recognizing that their clients often didn't have phones and they didn't have internet access, and the only way for them to stay in the program was to be seen in person, albeit less frequently. So a lot of the programs reduced the number of times patients had to show up, and that reduced their exposure to COVID on public transit if they had to be on transit. It also reduced their exposure in their waiting rooms. And for this woman, she talked about how the less crowded waiting room was really important because she had HIV, and she was really worried about being exposed to COVID. The other thing that happened was, so perhaps patients didn't come as frequently, and they couldn't. There were fewer people in the waiting rooms. But when they did arrive, they talked about sometimes having to wait outdoors because they couldn't go in, and that hadn't been a problem in the past. But during COVID, a lot of the coffee shops and anything around were closed, so they actually were standing outside in the winter, which they found quite problematic. Before COVID started, for the programs that were open, they had they told us almost no no-shows. So people always showed up for their appointments, and that changed during COVID. And they attributed it to a number of things, including the COVID housing, the change in the unregulated supply, and the amount of benzos in it. So they said some people, when they were using the unregulated supply, would be so sedated that they wouldn't show up for their appointments, and they worried deeply about them and the overdose risk that they would experience because of the change in the drug supply. And some people didn't show up because when they could get shelter, they didn't have much choice. So if they had to go somewhere far away to get a bed, they'd go and get it, and sometimes that meant that they couldn't make it for their appointment. The programs also tried to be resilient for their clients, and they started offering additional services. So patients who had prescriptions for psychiatric medications couldn't get them, so the Safe Supply prescribers started prescribing those as well. They became, the programs became places where patients had priority access to vaccines when they became available, and they were a trusted source of information about COVID-19. If you read the one in orange, I remember this woman talking to me. She said, she asked her doctor, "Oh my God, is it true that if you have blonde hair, you're more likely to get COVID?" And her doctor said, "No, that's ridiculous." But she trusted her doctor at a time when there was so much misinformation and people didn't know who to trust. And the Safe Supply prescribers and their staff were really important sources of information. And one thing I would say is that so many things closed without a thought given to the people who depended on those very services on a daily basis. So something as very basic as a toilet was not available to some people. And if you read that quote, it says, especially clients not having access to the washroom, a lot of people, they've been waiting for days to take a poop and 20 people waiting to use, and when they get there, there's 20 people waiting to use that bathroom. So the impact on the clients was profound and just plain awful. That's a duplicate slide. So what are the key ideas here? The story of COVID and safe supply programs isn't linear. It's not consistent across time, place, or person. It's hard to tell the story because there's so many caveats. It isn't all good. It isn't all bad. It's still evolving in a lot of respects. There's uncertainty about what changes have remained in place. So less frequent appointments are great for some people. And some of the services that were offered before COVID were never reinstated after all the restrictions were reduced. A lot of drop-ins are no longer available. The toxic drug supply changes during COVID created many unexpected challenges for safer supply programs, which were new, and trying to figure out how to do what they were going to do, and then they had to figure out how to do it in the context of COVID. And there's a lot of concerns about program sustainability in the future, about their funding and their human resources. So thank you. I hope I got that close to 7 minutes. There you go.
Thank you, Carol. That was very close to 7 minutes. Well done, especially if you started with 12. Excellent. All right, that brings us much closer to home. Well, I can't call this home, but Chris, up to you. I think we will hear Chris Gough is an executive director at the Canberra Alliance of Harm Minimisation and Advocacy. Chris identifies as a person who uses drugs. Welcome to have a community member on stage and has many years of experience in peer-based harm reduction. Chris is currently the president of the Australian Illicit Injecting Drug Users League. Floor is yours, Chris.
Thanks, Matt. Okay, thanks very much. I similarly have a fairly long presentation. So instead of cutting it back, I'll shoot through some of the data fairly quickly, and you can always grab a copy of my slides if you want later on. Firstly, I'd like to acknowledge the traditional custodians of the land on which we're meeting and pay respect to elders past and present. CAHMA is funded by ACT Health, as well as the Capital Health Network, and this funding was... Stand in front of the mic just for the... Oh, sure. And the funding was provided by ACT Health. So what is CAHMA? CAHMA is an integrated harm reduction service. We are a member of the Australian Illicit and Injecting Drug Users League national network of drug user organisations. We are peer-based, so everybody who works at CAHMA has lived experience or living experience of drug use and of using drug treatment services. And we're a member of ATOD. ATOD is the Alcohol, Tobacco and Other Drug Association of the ACT. Our principles are around grassroots community programming, expertise through experience, and in particular community development. So everybody that works at CAHMA, or the vast majority of people who work at CAHMA, have actually come up through our volunteer program, have been users of services in the ACT, have wanted to give back and have come, started off as volunteers, and then we use a strength-based approach to put people into different roles. And we believe in partnership, a lot of partnership. So these are some of the programs that CAHMA and The Connection, which is our Aboriginal and Torres Strait Islander program, what we do. We have a drop-in centre. People can drop in from 10 till 4, 5 days a week. We run an naloxone program, a volunteer program, health promotions, lots of different stuff, and peer treatment support. So in the ACT, in the last half of 2021, we had a lockdown in the ACT, a community lockdown. And in particular, a positive case was confirmed in first 1 and then 2 housing unit blocks in the ACT, and the decision was made to do a hard lockdown on those 2 sites, which obviously is incredibly problematic because the housing was for marginalised communities, in particular people who use drugs, co-occurring mental health needs, ageing, complex care, you name it. Those were the cases that were in these 2 particular locations. So we were brought in on day 1 of the hard lockdowns in these areas to provide advice to governments. And then later on, so what happened was in the first housing tenement building, they were locked down for 14 days. The second one, though, Ainslie Village, was bigger. It was about 180 people in that housing. It was like a spread out. It was about 12 different units, each that contained 8 people, and we kept on getting positive cases, and they kept on extending the lockdown up to a month. And then after that, the cases in our marginalised community really began to spread through our community, in the general community, and then eventually the ACT government stood up a facility called Ragusa, which was a quarantine facility, and the first quarantine facility in the world that had an integrated support hub. So there's us in our get-up, getting in there to the red zones. And I'll just say lots of the people who did this are in this room. Hand up if you're from CAHMA. Come on, all of you. And so this was well and truly outside our comfort zone. We're not clinical service providers, but we did really well in this situation. So what was our role? Well, communicating with residents was really, really important. Residents didn't know. The decision was made over a single night. People just woke up and barricades were starting to be put up and vans were arriving and people were getting tested. So nobody really understood. Nobody had any chance to get any of their medications sorted out. No notice whatsoever. It just happened. The other thing that happened is there weren't many clinical staff available, nurses and doctors, especially in the first week. Clinical staff tend to have much more specialised, how should I put it? They have a much more ordered and structured system of work, especially in big government departments, and they couldn't mobilise as quickly as we could. So in that first week, it was really important. We got in there doing daily welfare checks, teaming up with the medical staff that was available to complete needs assessments was really important, and then helping with testing and vaccination support. And one of the big roles was that Ainslie Village and Condamine Court have highly marginalised community members who often don't trust health service providers, certainly not when they're coming to their front door. And so CAHMA acted as a peer organisation. It acted almost as a vouch for people. So, hey, we're from CAHMA, here's ACT Health, or here's directions, and kind of vouching for the service. And we were able to get access to the vast majority of people in both of those 2 housing tenements. But another big part of what we did was in the provision of NRT, cigarettes and alcohol to dependent residents, as well as care packages. And that was something that you can imagine government did not want to do under their own name, but luckily acknowledged that, and luckily in our Liquor Act in the ACT, we have, it's all under a harm minimisation model. And so it allowed us to do assessments on people's nicotine and alcohol needs, and then provide that over the period of, in some case, over the period of their isolation. And the other thing we did was we flowed this this frontline in the red zone work into our broader complex peer treatment support system to help people who needed to get on pharmacotherapy programs and had really complex needs in terms of drug and alcohol treatment, mental health, and any other really treatment that they needed. Yes, so we provided, it was probably around $40,000 worth of alcohol and tobacco over that period in time. Why? Because if you want people to isolate, you need to provide them with comfort. And so we were really clear that it wasn't okay for people just to say, oh, well, you can, guess what, you're detoxing now. Not only, and there were some clinicians who that was their preferred approach. And so we had some robust conversations about that. And we actually tried and we offered people NRT or a pathway to medicated detox within their own home. And we did that in a few instances and we supported people to do that, but we didn't have, to my knowledge, any successful cases because it's really it's highly it's not the right. It's not the right environment. You need to be on top of everything when you want to detox. You need to be able to get out. You need to be able to run around, and so it just simply wasn't the right time. So these is kind of the numbers of clients we supported at Ainslie Village, blue being cigarettes and lighter blue being alcohol. We did a lot. Every day we used to go around and do a morning muster, make sure that people had what they needed for the day. Almost everybody at Ainslie Village smokes. So it was a big draw card as well for us to be able to provide information, help people identify their needs for the day and then provide those needs. And the kind of issues that we found during this response, overall, we found the ACT system really excellent. And we had already done a piece of work before we were locked down, doing COVID guidelines for methadone and for buprenorphine treatment. And we have a fantastic service provider in Directions Healthcare Services, Bronwyn. Up the back here is the CEO, and so we'd already done a lot of this work around how we're going to get people their takeaways and make sure they can socially isolate. And so there are a number of options there, which was really lucky. But there were absolutely no options for people with methamphetamine dependence, and we had and there is, in fact, in Australia, there's no pathways for methamphetamine pharmacotherapy at present, which is a big drawback. We also found it quite difficult with some service providers to get people inducted onto methadone. This was well and truly out of clinicians' comfort zone, providing methadone, just inducting someone onto methadone when they're at home and when they can't eyeball the person themselves in front of them in a normal appointment. But we have some fabulous clinicians in the ACT, and we also used a lot of. We found that one of the tricks was that you didn't just have one service that was providing these services for Ainslie Village, for example, but you actually relied on the pathways that the person already had access to and the existing relationships that person already had with healthcare services. It was the only way we could manage. And then there were a lot of problems with drug criminalisation as well. So we had just decriminalised cannabis. And so that was fun, trying to navigate buying cannabis for people and delivering it. And then when dealer wouldn't see us, and it was crazy. But so there was a lot of problems with drug criminalisation. And I must say, a lot of frontline government workers were absolutely fantastic. So one of the things we did, for example, is we used to do bespoke packages of groceries, so anything that the person wanted. Another big draw card from us was people could ring and we'd say, what do you want? Okay, so let's get you bread. Okay, what you like, meat, this meat, that meat. What do your kids need? And so actually we were able to give people what they would buy at the shop, not what some healthcare worker thinks they need. And we could, let's just say, if people knew how to source their drugs, they could slip that in there, and it was their groceries and no one else would open it. And we had that tacit agreement with government. And as I said before, there were some difficulties with punitive responses. A few clinicians thinking, oh, well, we shouldn't be supplying any of these drugs. This is a great opportunity for you to withdraw. And as I said, it was an option that we offered, but not our preferred in a public health crisis. As I said before, CAHMA's role grew throughout the lockdown. So in the end, we ended up, after the Ainslie Village lockdown was over, we ended up partnering with ACT Health Community Engagement Service, the COVID Response Service, the Home Care Team, the ADS COVID Contacting Team, and essentially where ACT Health was stuck, they would ring CAHMA. We turned our drop-in centre into a 7-day logistics centre and worked pretty hard. All right, so look, I can see I'm already over time. So we did about $70,000 worth of care packages, about $50,000 worth of brokerage, including phones, Xboxes, laptops, bespoke groceries. That's kind of how it looked throughout the period. And over and all, we did 211 closed treatment episodes and 1,355 occasions of service. And then that's just the COVID stuff. The complex peer treatment support. So the COVID team used to flick to our complex peer treatment support team for all of the really complicated stuff. And again, quite a lot, 89 in a period of about 3 months with 184 occasions of service. So thank you to the CAHMA team, to Directions Healthcare, to Ainslie Village and Condamine Court residents and all our community, ACT Health, the YWCA, Leisure ACT. I haven't got ATOD there, it was there before, but thanks to ATOD as well. And thanks for all of your time today.
Thanks, Chris. That was great. As I said, I have a short time span of focus, but I was focused from the beginning till the end. Sorry for being a bit aggressive standing up in the middle of it. But we're good on time. We have 25 minutes left. We have 2 more fantastic presentations, so hopefully we have about 10 minutes for some questions from the room and have an interaction about so many diverse topics that we can talk about anything in this session. So the next one up will be Philippa. She's originally trained as a registered psychologist, spent 25 years in leadership roles within New Zealand public sector spanning from health, social housing and tertiary education sectors, and joined the New Zealand Needle Exchange Programme as the National Operation Manager from 2020. Over to you, Philippa.
Thank you. Ina iwi, ina mana, tēnā koutou katoa. As you know, this conference is being held on the lands of the 5 tribes of the Kulin Nation, and I wish to acknowledge them as traditional owners. I would also like to pay my respects to the elders past and present and Aboriginal elders of other communities who may be here today. I acknowledge that the land is unceded, that it always was and always will be Aboriginal land, and I acknowledge the disproportionate negative impact broken drug laws have and continue to have on Aboriginal and Torres Strait and Islander peoples. Firstly, just a little bit of context about who we are, the New Zealand Needle Exchange. New Zealand was the first country in the world to establish a state-funded nationwide needle and syringe program, and our program has been running for 35 years this year. Today it comprises 20 static needle exchanges, 3 mobile services, 200 pharmacies and other outlets, and we employ approximately 100 staff nationwide, 95% of whom have lived or living experience of injecting drug use. The project I'm talking about today involves the South Island only, and on that other graphic you can see the range of services that we offer. We're really pleased that drug checking has recently been added to our service list, and we are establishing a continuous, always-on drug checking service. So in terms of this project, in 2022, the National Health Service offered special funding for COVID-19, and it was about trying to improve the uptake of COVID-19 vaccinations amongst people with mental health and addiction issues. And in particular, it acknowledged that Maori and people with lived and living experience of drug use had lower COVID vaccination uptake at the time, and of course were reluctant to attend mainstream health services due to the stigmatisation that they experience. The fund also recognised that peer workers with lived experience of drug use were best placed and most effective at engaging with clients and building trust. Whilst the primary focus of this was on the COVID vaccination uptake, the fund also enabled and recognised the opportunity to extend services or to extend the service to offer other preventative health services. So given our clients in the Needle Exchange program the target population for the National Hepatitis C Action Plan and a target setting for that, we thought this was an amazing opportunity to add on Hep C screening. So it was purely opportunistic in that sense. So this was a two-pronged thing: increase COVID uptake amongst our people and undertake Hep C screening and treatment. We took a collaborative approach, but the success of this really came down at the end of the day to it being peer-led. We had learnt a lot from previous INSU conferences where we'd seen great examples of peer-led approaches to Hep C testing, so we drew on those. But we also drew on our expertise in the South Island, where we have had for 12 years a Hep C community clinic co-located at our busiest needle exchange, and it is a collaboration between Hep C nurses and peers, and that particular service has some of the highest testing and treatment rates in the country. We also had an amazing amount of institutional knowledge and intelligence through our long-serving needle exchange managers and staff, and they know their community very well, and they know the local drug market because it varies significantly across Aotearoa. We'd also done previous research a few years ago, which was subsequently published, that demonstrated and underscored the importance of needle exchanges as a testing site, demonstrated the effectiveness of peers' engagement in encouraging our community to get tested, and really demonstrated that non-clinical staff were more than capable of leading testing. So the target locations, we primarily focused on our needle and syringe outlets, because obviously we have a captive audience there. But we did work with other community providers who are often located near us or were also serving our clients perhaps in other ways. And then we went to some sort of market day and events where it was appropriate. There was a significant amount of planning and logistics involved in this because we covered the entire South Island, and so we worked closely with the outlet managers to schedule visits, sometimes 4 and 6 weeks in advance. We have had the National Hepatitis C campaign launched last year in New Zealand, so we used all of the collateral around that to promote the service, to put posters up, a couple of weeks in advance of us going to that location. We found it necessary to go back several times, in some cases 5 times, to the same needle exchange. That was about building confidence with the community there, and once we'd been once or twice, people told their mates and more people came along. And also we needed to be cognizant of the fact that you needed stand down time between vaccinations, so we would go back at regular intervals. We found that where regional managers and outlet managers, who are all peers, and our peers have a very close connection with the community, we had better engagement because those people on site knew their clients, knew the local drug market, and knew how to reach people who were perhaps working or living in rural areas. We also had incentives. That was a very important part of it. Because this was a COVID project, we prioritised the largest incentive for that. So we had $50 vouchers, grocery vouchers for people who got another vaccination, $30 vouchers for people who took a test, and $25 voucher if you brought a friend. And they were really important for getting people over that reluctance. So that was the approach. We paired with Hep C nurses when possible. In the South Island, a lot of our Hep C nurses are fantastic, but they only work part-time. The peer worker, who I'll talk about in a moment, sometimes worked with the outlet manager. If somebody was positive, had a positive antibody test, they would be referred to the Hep C nurse for RNA testing. And in some cases, the Hep C nurses worked with us on site and took blood straight away. But that handoff and that close relationship between the exchange and the Hep C nurse was really important to manage into treatment. In terms of the COVID vaccinations, that was in some ways a bit easier. A lot of pharmacies around the country were doing COVID vaccinations, so we could send clients along the road to the closest pharmacy. They'd come back with their evidence of their vaccination and they could get their incentive. We also worked with some people called the jabber walkers, jabber meaning, getting a jab, and waka being the Māori term for a canoe, which was actually a camper van. And so in some cases we were working with the public health system. And we'd have our van for Hep C testing and their van for doing the jabs, the COVID jabs. We have limited information about our clients, and in the face of that, and the fact that at the time this fund was launched and we applied, there was only 50% of our target population had taken up the vaccines, and New Zealand is not on track to meet elimination targets at 2030. It's actually currently 2037. We're short of our target in terms of the World Health Organisation, the number of needles per PWID, and the last zero prevalence study was done a decade ago. So we've got a bit of an absence of information. So we took this opportunity to collect data from our clients through a questionnaire, which was around understanding their COVID vax status, their progress through that journey, demographic information, drug of choice, Hep C status, previous treatment, etc. But we also used a second approach, and that was more qualitative. Our peer worker wrote a journal after every event and visit, which recorded the stories and the personal stories in an anonymous way of the people that he met. And I think we learned as much through that as we did through collecting the information in our questionnaire. And again, we heard the stories where many of our clients faced on a daily basis stigma and discrimination, which was a significant barrier to them getting the care they needed. But on to the rock star. So the guy on the far right with the T-shirt, which goes like this, because our campaign said stick it to Hep C, that's Pete, and he's given me permission to speak about him. But Pete had a 30-year injecting career. He was treated for Hep C with interferon. He's got qualifications in counselling. He's worked all over the South Island. He's connected to past and current PWID community, and he understands all the barriers, lifestyle issues, everything that goes with that package. And it was really Pete and the person that he is that enabled the success of this project. We did all the background work and he was the upfront guy really making it happen. Part of this fund was also about building peer capability, so we invested a lot in Pete and developed his skills. But one of the lovely, unexpected outcomes of this was we've been approached by a number of our clients, also peer workers, but a number of people in our community who want to come and do this work now, want to be trained, want to be out there and helping their colleagues. So that's been a really important spin-off. And the last slide, our results. We're really delighted with the results. We had a 94% response rate. So for every person that we engaged with 615 people, that was a few weeks ago, 577 took a point of care test, 76 were referred to care or to treatment. We're yet to go back and see how many of them were RNA positive and continued. We got a good uptake of COVID-19, and it was interesting to know that many of our community had already had in New Zealand, it was 2 vaccinations plus 2 boosters. Many of our community community had already taken up the first 2 vaccinations, so the focus tended to be on boosters. So next steps, we've managed to get additional funding to extend this into the North Island, and we're also doing a pilot in the far north as well. So from sort of reaching out and taking this opportunity and getting it working really well in the south, we've been able to develop other opportunities to extend it. We've been able to recruit peers to come and join our organisation and to get trained. And what we have realised is that there's still a lot of myths out there about treatment for Hep C. Still a lot of people think about interferon and the experiences that their friends had. So there's still a lot of work to do to educate both our own staff and clients. But the one lesson that I've put here that I would, I think was really important is the need for flexibility and the need for the process to be reasonably organic, because in every location the circumstances and the environment are different. And it was so important to learn and listen to our local teams on the ground, our peer workers, because they know their clients and they know their region. And that combination of that with Pete is really what made this successful. That's it from me.
Thank you. Okay. We're almost at the end of the session. We have 11 minutes left. I have a close eye to it. So prepare your questions. We have one more fabulous speaker. I don't know about online participation. Can they ask questions as well? It's just to not completely ignore them. Okay, well, that's yes, no? Okay, right. I will have a look while just in the meantime. But all of you, as you are here, have the priority. Come walk up to mic if you want to have a question. We have hopefully a few minutes at the end. And of course, I invite everybody at the end of his presentation to sit here, answer questions. And obviously, if you want to hang around a little bit, they are here to reply to your questions. So, Omar is one of the pioneers, having over 2 decades of experience designing leading harm reduction programs in Bangladesh. Very happy to have you here. He's a well-known advocate for the rights of people who use drugs. He led the formation of several community-based groups, notably the network of people who use drugs in Bangladesh. It's really great to have you, Omar. You have the floor.
So my presentation will be very short and very to the point. In Bangladesh, harm reduction program started back in 1999, and till now it's continuing without that much interruption. So today I will talk about the community participation and community engagement in the COVID-19 pandemic situation. So you can see the picture. It's a Dhaka city, a typical city in South Asia, one of the most populous cities in the world, 30,000 inhabitants per square kilometer. So you can imagine. Over 7,000 people who inject drugs residing in the capital, in Dhaka. Altogether in Bangladesh, 30,000 people who inject drugs are estimated. And if you consider altogether the drug user, then it's around 7 million. So 30% of the people who inject drugs are homeless and lives on the street. Average monthly income, you can imagine, USD 15. So in this context, COVID-19 came and did his mastery over us. So COVID-19 devastating our regular phenomena, regular work, as well as the in the life of people who inject drugs. So what happened? Decreased income and increased drug cost. So it's super imbalanced condition. And then 100% all drug users are affected. Among them, 30% people who inject drugs lost all income in Dhaka city. So 69, around 70% people who inject drugs harassed by law enforcement agencies and the communities, greater communities. 92% female who use drugs face gender-based violence, including physical and sexual harassment. So within this context, the two major things happened. One, severe hunger, and two, withdrawal symptom. So in Dhaka city, here and there, people who inject drugs were lying down, and no one cares. And outreach team, the program implementers cannot move, so it was locked down, and law enforcement agencies were very harsh. So what was happening at this moment, you can imagine. At that time, NPUD, a network of people who use drugs in Bangladesh, stepped up to provide vital food assistance for street-based people who use drugs. So NPUD, who are NPUD? NPUD is the federative body of the self-help groups across the country. So NPUD come up with their courage. When international agency, donor agency, implementers, governments just sitting behind within the lockdown, NPUD come up. So what they did, they started food distribution with their own way, without taking any fear. They straight to go to the field and start helping people who use drugs. And in this way, whenever they feel government have seen, yes, it's working, then government came forward. Government provided movement pass and PPE equipments. UNAIDS came forward with some small funding. Save the Children, ICDTRB, who were the principal recipient of Global Fund supported HIV program. They came forward with few budgetary allocation, and generous contributions came from hundreds of individuals. So issue is, whenever you're in a crisis, there are two options. One is we can be down, and another can be, yes, let's start from the crisis, we can unite. So NPUD started the process, and other partners came together to support them. And over 8,000 meals served monthly for 4 months, NPUD. So it's huge thing, huge arrangement. What happened after? Yes, drug user community, they cannot do, they are always disturbing this sort of stereotyping, this sort of connotation. It's quite removed for the time being, and it demonstrates the power of community, the grassroots organization, and highlighted capabilities. Yes, they can really move forward within the given crisis even. So what is our learning? Learning is community strength, courage, and advantage frequently undermined. And involvement is often limited to tokenism. Unfortunately, whenever you feel, say for example, Global Fund supported program, there are lots of things, community engagement, what sort of engagement? What kind of engagement? If you are really involved with the Global Fund or any sort of funding proposal and the implementation, you can see it's all about tokenism. Come, sit, talk, and the format template is same remains as previous. So this tokenism, this sort of initiative, inputs initiative, proved that no, tokenism is not enough. We are the people. We can really change the situation in field level, in the community level. So, insufficient investment in community system strengthening. We always talk about community system strengthening, always, but in terms of money, in terms of allocation, in terms of funding, there always it's little. However, only the community has the determination and courage to support the cause wholeheartedly. That's all from my side. Thank you.
Thank you, Omar. Okay, I'll just ask you, so I think we need one more chair, but if you would like to sit in the front. I know the session is over in 2 minutes from now, but we don't really care about rules in harm reduction. So if you have a question, please, this is your moment. And of course, after you have some time to ask any further questions, feel free to come up to the mic and... Okay, or there's even an assistant, somebody that can help. That's even better. So who has a question from the room? Perfect.
For Chris, being on pharmacotherapy during COVID was such a huge anxiety for everybody, I think. So I would hate to imagine what it was like for those people that were in lockdown. So a couple of questions is, one, how many people did you have on your team that would go out and do that home care? And did you have anything in place that if COVID hit your staff and volunteers, how you'd be able to manage that?
Yeah, sure. How many, Natasha, how many staff? Yeah, so we had about 18 casuals, and we found, so we had about 18 casuals and about... Red zone workers, and then on top of that we had frontline workers receiving Right, yeah, so we actually expanded the workforce quite considerably when we got the funding, and we were able to do that because of our community development model. So we put on an extra 5 or 6 staff, and then they were working four people a day, four staff workers for each shift 7 days a week. And about 18 to 22 people in total. What was the other half of the question?
So, like, say, for instance, if, because I know at P-based harm reduction, what we did is we split into 2 teams.
Yep.
So if, COVID hit, team 1 could run the NCP for the whole week. So did you do it that people didn't cross over, or...
No, we had, we were working inside the red zones as well. So when we were doing that, we had 48-hour testing for all of our staff, but we didn't have enough people to split it. We couldn't work that one out. So we we had to close our drop-in centre. And so we closed our drop-in centre and just turned the whole thing into a logistics hub, essentially. And then people tested as often as they could, and we were cautious and followed the regulations in terms of when we were going into the red zones. We were very careful. But yeah, we did follow that model of splitting our workforce in 2 once we came back to the centre, but that was after this period of lockdown. Yeah.
So one more question, I think.
Thank you. My name is Jofré from Myanmar. And the COVID-19 actually is the global pandemic, could probably happen next time, no? Maybe with another virus, we don't know. but we also experienced so much difficulties within the COVID period. Like I listened to the last presentation is distributing the food to the communities. But in here is like, what should we do before maybe if there is another pandemic, we should prepare for the community resilience, right? So maybe distributed food may not be enough, and we need to create job opportunities for the BWID or BWD who are receiving the harm reduction services. So we are thinking about the a kind of social business or social enterprises organizing with the people who use drugs. But in here, the opportunity is like very limited funding for providing the livelihood activities or the income generation for the people who use drug. What about your experiences? You all can answer. Is there any initiatives for the creating the job opportunities by means of social business or social enterprise in your experience? And also, could you please share about any financial issues that would be useful for us in Myanmar as well? Thank you so much.
Okay, I'm just, because it's a very big question, I'm going to throw in an additional question, and then you can see which one you can answer, and we go back from you, Zoe, here, and then we will close the session. Is that okay? So you have a question around if you have any opportunities for social enterprising, and I'll throw in another question which I ask myself a lot, because I would like to never think about COVID-19 again. So sometimes I ask myself the question, what lesson would I like to have known before the shit hit the fan? And I'm not going to ask you to make a really, really long statement. If you can try and wrap it up in a few words, I still undecided for myself. If you have a keyword, a buzzword that comes to your mind, I invite you just to throw that out. And we go from Zoe here. And if you would have anything in addition to social enterprising, I invite you as well. Thank you. Maybe you can
here. In the harm reduction field in Toronto, most people who work in it are people who use drugs. And so when COVID hit, people who use drugs and people in harm reduction really leaned into it because we've already been addressing the toxic drug death crisis. So we're already preparing to, everything closed down on people. People were closed outside. People went into encampments. People couldn't get their medications. Like, it was really bad. And people organized themselves because in harm reduction, a lot of the work that we all do is about mutual support. And I think that's ingrained in many of us to just step into something. And so I would say I have a lot of pride in everyone who did that. And one of the other things we did for financial is we live in a really privileged place compared to Myanmar, but we used neighbors to fundraise, and it was called the Encampments Support Network because, thousands of people were living in public parks. So we used it as an opportunity for all these people who were unemployed and in lockdown to then start organizing and start helping people outside. And that changed also the discourse about how we help people. It shouldn't just be on organizations who have now shut their doors, but us as neighbors should be helping each other as well. And when I think about COVID in terms of the future, because we're still in COVID, I would just say that our healthcare systems around the world do not have the capacity to address these kinds of crises because of capitalism. And it was really shown in this pandemic that our healthcare systems could not address they could only handle one thing at a time, and they couldn't even handle that well, including access to PPE. So in the future, in our preparedness, drugs and vaccines need to be a common good that we all have access to around the world. And we need to be having those conversations about how we remove the profit imperative from drugs and PPE and all the other things that we needed for people's survival. Yeah. So, yeah.
Marcela, maybe it's a hard question for you as your perspective from prison, but if you have just a few words on, indeed, what the lesson learned.
Yeah, unfortunately, I think there haven't been many lessons learned in the case of prison population because of their context of deprivation of liberty. people in detention cannot, for example, self-organize. They cannot mobilize by themselves because it's prohibited for security reasons. So they really relied on a social organization that come into prison and provide support and provide harm reduction or health services, which are already very limited. So it's a population that is already underserved. And so I would say that, I don't know, I'm just thinking out loud, but I'm related with the plenary session that we had this morning, and when Cassandra talked about the need of decolonize and not only harm reduction, but also health services. And I think prisons is a good example of that. We need to, for a future crisis, because it's gonna be other health crisis in the future, we need to work for a good health system that put people at the center. And at the moment, people deprived of liberty is absolutely silenced and ignored.
Sorry, the time is going very fast. We're already 10 minutes over. If anyone has a very short remark on what lessons, can you wrap it? No? Anyone else in the group? Yes, sure.
Before I forget, because I'm sorry, but thinking on maybe good practices that came up with the report I showed. There was a good example in Kenya. So during the COVID pandemic, they managed to implement first prison-based medication-assisted therapy. And this was precisely because of the pandemic. They used this like political opportunity because they didn't want to get people out and risk spread more infections. So this was a good opportunity to bring this system into prisons. Yeah, that's the only thing.
Carol, Pauline, Chris, Omar, anything to add from here?
Just that, I mean, it's about giving the space to the community of the affected community to self-mobilise and to build leadership, And so that looks very different wherever you are in the world. But I think certainly providing a physical place where people can meet, people can feel ownership over that space has been really effective, at least in Australia, at bringing people together and starting to build a community, develop that community, offer employment opportunities and skills development, and then the next kind of step is that leadership stuff, you know, where you're actually building leadership and building organisational strength as a community.
Excellent. Oh, Omar, yes.
I totally agree with his statement. In addition, to me, it's all about the negotiation with the power, and it's power relation. And the people who use drugs always seen as are always in a position of marginalization. So whatever you think, health, social safety, and even personal liberty, human rights, all things very much interrelated with the legal and situational purview. So it's all about negotiating with the system. So how? So first thing is organizing. Second thing is absolutely growing leadership and allocating fund in that particular area and organizing and learning from other countries and doing some trial and error and come up with that. Of course, food distribution is not the ultimate solution and it's not the sustainable approach at all. But we can start at least. Thank you.
Okay, thank you all very much. The title of this session starts with lockdown. I'm not going to lock you all down. We are quite a bit over. I hope they allow me to keep my Dutch passport. We are very, very religious with time. Yeah, I would love that one, actually. Thank you all very, very much. This was a really, really fantastic session, very broad. Thanks to all the speakers, and I hope to see you further down in the conference. Thank you.